Cardiac arrhythmias remain a major source of morbidity and mortality in developed countries. Cardiac arrhythmia is a disturbance in the conduction of impulse through the myocardial tissue. These cardiac arrhythmias may be caused from disorders in pacemaker function of the sinoatrial node, thereby resulting into tachycardia, bradycardia, cardiac arrest, atrial flutter, atrial fibrillation, and ventricular fibrillation. Hence, the antiarrhythmic agents are also termed as antidysrhythmic drugs or antifibrillatory drugs. So, this may be defined as the drugs that are capable of reverting any irregular cardiac rhythm or rate to the normal. So, sometimes arrhythmias are the most important cause of sudden cardiac death or cardiac arrest. Okay, now we will see the development of antiarrhythmic agents just overall looked. During the last 20 years, our understanding of cardiac electrophysiology and fundamental arrhythmia mechanisms has increased significantly, resulting in the identification of new potential targets for mechanism-based antiarrhythmic therapy. However, antiarrhythmic drugs development has remained slow despite much effort given or limited understanding of that role of various ionic currents play in arrhythmiogenesis and how they are modified by arrhythmias. Multi-channel blockade, atrial selectivity, and the reduction of the risk of adverse drug events have all constituted in main theme of modern atrial fibrillation drug development. The increasing appreciation of ventricular arrhythmias as a marker of underlying heart disease and therefore a potential drug target led to the development of multiple new antiarrhythmic drugs. So the most currently available antiarrhythmic drugs have been derived from naturally available compounds, for example like quinidine adapted from the compound from the bark of cinchona tree or were originally developed from other purposes. For example, amiodarone and sotalol were initially developed for the treatment of angina. The multiple electrophysiological effects of each of these compounds make mechanism-based therapy difficult. So, definition of arrhythmia is the deviation of heart from normal rhythm. So, what is our normal rhythm of heart? So, normal heart rate should be 60 to 100, not less than 60 and not more than 100. They should origin from sinoatrial node. Then third one is cardiac impulse should propagate through normal conduction pathway with the normal velocity, and the heartbeat that is too fast is called as tachycardia, while the heartbeat is too slow then it is called as bradycardia. So let's see the conduction system. So first of all, sinoatrial node, then to atrial syncytium, then junctional fibers, then it transfers to the atrioventricular node, then AV bundle, then bundle of branches, Purkinje fibers and ventricular syncytium. So that was the normal path for the generation and passing of the impulse which are generating the heartbeats. So let's see the symptoms of fluttering in your chest, racing heartbeat, slow heartbeat, chest pain, shortness of breath, lightheadedness, dizziness and fainting. Okay, all of us know that pacemaker, you have most seen or you have listened about the pacemaker. The pacemaker is a small device that's placed in the chest or abdomen to control abnormal heart rhythms. This device is used to low energy electrical impulses to promote the heart to beat at a normal rate. Let's see the classification. The antiarrhythmic drugs are categorized according to the Vaughan-Williams, that is VW classification system. The VW classification of antiarrhythmic drugs are divided into four main categories based on their dominant electrophysiological properties. Recently, it is being updated to more subcategories. They are as follows. Let's see it. So, there are four types of classes. In that, first is membrane stabilizing agents, that is sodium channel blockers. Second one is anti-adrenergic agents, that are beta blockers. Third one, agents widening AP. Then fourth one, calcium channel blockers. So let's see the first class, membrane stabilizing agents. In that again three classes comes. So moderately decrease the zero phase, little decrease in the zero phase, and marked decrease in zero phase. Okay. So we will see in the next slide that are the phases. So drugs, quinidine, procainamide, disopyramide, lidocaine, profenanon, and flecainide. So these are comes under class 1. Let's see class 2, anti-adrenergic agents, that is beta blockers, propranolol, esmolol, and sotalol. Then third one is agents that are widening AP, amiodarone, dronidarone, dofetilide, and ibutylide. And last fourth one is calcium channel blockers. So in that verapamil and diltiazem. So class 1, antiarrhythmic drugs act by blocking voltage sensitive sodium channels via the same mechanism as local anesthetics. The decreased rate of entry of sodium slows the rate of rise of phase 0 of the action potential. So quinidine sulfate is the main drug from this class. It is the member of family of alkaloids which is found in cinchona bark. It is the dextrorotatory. Then quinidine and quinine are structurally similar but differ in the effects of the cardiac muscles. The structure contains two basic nitrogens, of which the nitrogen is a stronger base having pK value 10. Because of the basic character of quinidine, it is always used as water soluble salt forms. These salts include quinidine sulfate, gluconate, and polyglucuronate. The gluconate salt is particularly suited for parenteral use because of its high water solubility and lower irritant potential. Let's see its mechanism of action. Quinidine is a membrane stabilizing agent. It interferes directly with the depolarization of the cardiac membrane. Quinidine binds with the voltage gated sodium channels and inhibits the sodium influx required for the initiation and conduction of impulses. This results in the increase in the threshold for excitation and decreased depolarization during phase 0 of the action potential. In addition, the refractory period, action potential duration, and the ERP and APD ratios are increased, resulting in decreased conduction velocity of nerve impulses in the myocardium. So quinidine, uses of its quinidine is, so they can be used, alternative measures have been found to be inadequate. Quinidine is used to treat and prevent atrial fibrillation or flutter and ventricular arrhythmias. Quinidine also used to treat short QT syndrome. Then quinidine is an intra-erythrocytic schizonticide used to treat malaria. So from that class, quinidine class, we can see the procainamide hydrochloride is the example of this first class. So let's see its synthesis. So para-nitrobenzoic acid is treated with thionyl chloride, then it will gives us para-nitrobenzoyl chloride, that OH is replaced by Cl. Okay, OH is also nucleophile, as well as the chlorine from thionyl chloride acts also nucleophile. So OH hydroxyl groups is replaced by chlorine group. So it gives para-nitrobenzyl chloride. Again this treated with an diethyl ethanamine. Then it will give us a complex with that amine, the benzyl chloride complex with the amine intermediate, which again if we did its reduction with the tin and hydrochloric acid, it will gives us procainamide. Next is class 2 beta adrenergic antagonists. So in that propranolol, sotalol, esmolol, timolol, various drugs comes under these classes. This drug diminish phase 4 depolarization, thus depressing automaticity, prolonging AV conduction and decreasing heart rate and contractility. These agents are useful in treating tachyarrhythmias caused by increased sympathetic activity, and also used for atrial flutter and fibrillation, and for AV node return tachycardia. Okay, so therapeutic uses are hypertension, they can be used on angina, myocardial infarction, arrhythmias and heart failure. Next one are class 3. So in that potassium channel blockers or repolarizing prolongators, amiodarone, bretylium. So it mainly acts as by blocking K plus channels, that is potassium channels. It increases the refractory period, it increases the duration without affecting phase 0 and resting membrane potential. Then next is class 4 calcium channel blockers. In that verapamil diltiazem, they decreases the inward current carried by calcium, resulting in the decreased rate of phase 4 spontaneous depolarization. So what are the therapeutic uses of calcium channel blockers? That we can use it on hypertension, systemic as well as pulmonary, angina and arrhythmias. Rather than these 4 classes, other drugs are also used in the tachyarrhythmias. Adenosine is one of them. So adenosine inhibits AV conduction and the duration of effect is less than 60 seconds. So used as a IV bolus in SV tachycardia with narrow QRS complex. Then its adverse effects are bradycardia and AV block. Then next one is digoxin, which reduces conduction through the AV node and is useful in control of atrial flutter and atrial fibrillation. So last one, that clinical uses of all of this. So sodium channel blockers are also used as local anesthetics and anticonvulsants rather than antiarrhythmic agents. Procainamide can be used to treat atrial fibrillation in the setting of Wolff-Parkinson-White syndrome, supraventricular arrhythmias, then nodal and ventricular arrhythmias, and also on refractory ventricular arrhythmias. Thank you.